Hyponatremia is the most frequently encountered electrolyte imbalance in hospitalized patients, and among its types, hypotonic hyponatremia accounts for the vast majority of cases. Despite its frequency, it remains poorly understood and often mismanaged, especially in critically ill and post-operative patients. This session focuses on hypotonic hyponatremia in adults, with emphasis on pathophysiology, classification, and clinical relevance for advanced nursing practice. As nursing students, your role is crucial in early detection, continuous monitoring, and prevention of serious neurological complications associated with this disorder. Understanding why hypotonic hyponatremia occurs will help you move beyond rote protocols and apply rational nursing interventions in complex clinical settings. At the end of this session, you should be able to clearly define hypotonic hyponatremia and distinguish it from other forms of hyponatremia. You will understand the normal physiologic mechanisms that regulate water balance and sodium concentration in the body. We will then explore how disturbances in these mechanisms lead to hypotonic hyponatremia, followed by a structured classification of its causes. Finally, we will integrate these concepts with nursing assessment and clinical decision-making, which is particularly important in intensive care, post-operative, and medical surgical units. Hyponatremia is defined as a serum sodium concentration of less than 135 milliequivalents per liter. However, sodium concentration alone does not provide the complete picture. Most patients with hyponatremia also have low plasma osmolality, which characterizes hypotonic hyponatremia. In hypotonic hyponatremia, the primary problem is not sodium loss, but excess water retention relative to sodium. This dilutional state causes water to move into cells, leading to cellular swelling. Brain cells are particularly vulnerable, making hypotonic hyponatremia a potentially life-threatening condition. Clinically, even mild chronic hyponatremia is associated with increased risk of falls, cognitive impairment, prolonged hospital stay, and mortality. To understand hypotonic hyponatremia, we must first review normal water regulation. Plasma osmolality is tightly controlled by two primary mechanisms, the thirst center and antidiuretic hormone, also known as ADH or vasopressin. ADH is synthesized in the hypothalamus and released from the posterior pituitary. It acts on the renal collecting ducts by inserting aquaporin water channels, allowing water reabsorption. Under normal circumstances, when plasma becomes hypotonic, ADH secretion is suppressed. This results in excretion of dilute urine, allowing excess water to be eliminated and plasma osmolality to normalize. Hypotonic hyponatremia develops when water intake exceeds the kidney's ability to excrete free water. The most common underlying defect is persistent or inappropriate secretion of ADH, even when plasma osmolality is already low. When ADH remains active, the kidneys continue to reabsorb water, leading to progressive dilution of serum sodium. This creates a hypotonic extracellular environment, causing water to shift into cells. From a nursing perspective, this explains why fluid administration, especially hypotonic or excessive isotonic fluids, can rapidly worsen hyponatremia in hospitalized patients. Traditionally, hyponatremia is classified as hypovolemic, euvolemic, or hypervolemic. However, this approach has limitations because clinical assessment of volume status is often inaccurate. A more physiologically sound approach is to classify hypotonic hyponatremia based on the kidney's ability to excrete dilute urine and the regulation of ADH. This framework helps nurses and clinicians understand why hyponatremia occurs, rather than simply labeling it based on physical findings. In primary polydipsia, the kidneys are structurally normal and ADH secretion is appropriately suppressed. However, water intake is so excessive that it overwhelms renal excretory capacity. This condition is commonly seen in patients with psychiatric disorders, especially schizophrenia. Urine is maximally dilute, with osmolality below 100 milliosmoles per kilogram. Nurses should recognize that rapid ingestion of large volumes of water, even in a short period, can lead to acute symptomatic hyponatremia, including seizures and cerebral edema. Water excretion by the kidneys depends not only on ADH, but also on dietary solute intake, particularly sodium and protein. Conditions such as beer potomania and the tea and toast diet result in extremely low solute intake. Without adequate solute, the kidneys cannot excrete sufficient free water, even when ADH is suppressed. As a result, hyponatremia develops with relatively modest water intake. This is particularly relevant in elderly patients, alcohol-dependent individuals, and malnourished patients, groups commonly encountered in nursing practice. In advanced kidney disease, the number of functioning nephrons is markedly reduced. Although ADH suppression occurs appropriately, the kidneys cannot generate maximally dilute urine. The minimum achievable urine osmolality is higher than normal, limiting free water excretion. Consequently, water retention occurs, leading to hypotonic hyponatremia. Nurses caring for patients with chronic kidney disease must be vigilant about fluid intake and electrolyte monitoring, even when ADH regulation appears intact. Thiazide diuretics are a well-established cause of hypotonic hyponatremia. They impair sodium reabsorption in the distal tubule, reducing the kidney's diluting capacity. Hyponatremia often develops within the first 2 weeks of therapy and is more common in elderly women with low body weight. Patients typically appear euvolemic, making diagnosis challenging. Nurses play a key role in early identification by monitoring serum sodium levels and recognizing subtle neurological symptoms. The most common mechanism of hypotonic hyponatremia is failure to suppress ADH secretion. In such cases, urine is not maximally dilute, indicating ongoing ADH activity. ADH release may be stimulated by stress, pain, nausea, hypovolemia, or reduced effective circulating volume. This mechanism is central to most hospitalized cases of hyponatremia. Because direct measurement of ADH is unreliable, urine osmolality becomes a critical diagnostic clue in clinical practice. In hypovolemic hyponatremia, both sodium and water are lost, but sodium loss predominates. Common causes include gastrointestinal losses, diuretics, burns, and hemorrhage. The resulting volume depletion activates baroreceptors, triggering ADH release despite hypotonicity. This leads to water retention and worsening hyponatremia. For nurses, assessing intake-output balance, daily weights, and urine sodium levels is essential in differentiating causes and guiding management. Hypervolemic hyponatremia occurs in conditions such as heart failure, liver cirrhosis, and nephrotic syndrome. Although total body water and sodium are increased, effective arterial blood volume is reduced. This perceived hypoperfusion stimulates persistent ADH release, leading to water retention that exceeds sodium retention. Hyponatremia in these patients is a poor prognostic indicator, And nursing care focuses on fluid restriction, monitoring neurological status, and evaluating response to therapy. SIADH is characterized by inappropriate and persistent ADH secretion in the absence of hypovolemia or edema. Common causes include CNS disorders, malignancies, drugs, and postoperative stress. Patients retain water while continuing to excrete sodium normally, resulting in dilutional hyponatremia. Postoperative patients are particularly vulnerable due to stress-induced ADH release and liberal IV fluid administration. Nurses must monitor serum sodium trends, fluid balance, and neurological status closely as SIADH can rapidly progress to life-threatening complications. Please like, share, and subscribe, and leave your questions as comments.